All right. Wonderful. Starting to have some people come into the room, which is great. Good evening, everybody. Lovely to have you here today. We'll just give it a couple of minutes for everyone to jump on in because I think we're expecting a reasonably full house this evening, which is very exciting. Okay. All right, so we might get started in the interests of time and everyone getting out at a reasonable hour. So good evening, everybody, and welcome to tonight's presentation on the common non-compliances in RACGP accreditation and how to prepare. We have the wonderful Riley from QIP Consulting, which is the consulting arm of AgPal, with us this evening to come and take us through the top 10 non-compliances that practices experience after their visit with their accreditation. I was going to say, what do we call them? I keep calling them inspectors, but I know that's not the right word. So
Surveyors,
surveyors, that's right. Much more fancy. All right. So if I can just get you to go to the next slide, Riley.
If I could do my job properly, I would. There
That's
we go. Whoop, whoop, whoop.
There we go.
Oh
So
my
I
good
would,
Lord, what have I done? Hang on.
that's right.
Off to a good start. Sorry, guys.
That's fine. So I would like to commence this evening by acknowledging the traditional owners on the lands which we are meeting this evening. So for me, myself, I'm on the lands of the Wurundjeri Woiwurrung people of the Kulin Nations. I'd like to extend my respects to their elders past and present and acknowledge that this land was never ceded and it always was, is and will be Aboriginal land. So just a little bit of housekeeping to start with. So you will be muted on entry. If you have any questions you'd like to ask throughout the webinar, you can use the Q&A box, which if you highlight the toolbar at the bottom of your Zoom window, you'll see the two little chat windows. You can pop a question in there. We will hold all questions to the end, but please ask them away as we go through the webinar so that you don't forget what you needed to ask. The session will be recorded. Your questions will be asked anonymously, however, to protect your privacy. There will be access to the recording and the follow-up resources to this available on our website, but they will also be sent out in a post-event email. So just moving to the next slide. So if I could ask, when you are joining the webinar this evening, just checking the name which you are registered with Zoom as, and just ensuring that it matches the name that you registered for the webinar with so that we can mark attendance and issue your certificate. If you're not sure if your name matches or if you're not sure how, you can just pop a question in the chat and our back-end support person, Yvonne, can give you assistance. So I'd like now to hand over to Riley, there we are, who is a consultant extraordinaire and has the most incredible knowledge of all things accreditation. And we're very lucky to have her here this evening to share her knowledge with us and to upskill us all in our accreditation so we can also do really well at our next visit. So thank you very much, Riley, and I'll hand over to you.
Thank you so much, Nat. Appreciate it. So thank you everyone for having me tonight. What we are going to try and cover is the top 11 non-compliances because I'm very good at accreditation, but I'm very bad at maths. So when I was preparing these slides, I did give you a bonus one. So we'll be undergoing the top 11 non-compliances. We'll also be talking about the highest risk indicators that come up post-survey and the most common simple errors that I just absolutely hate to see because I know they can be so easily avoided. So a little bit of background about me and where I've been getting the information from these slides from. I did start off as the New South Wales client liaison once upon a time and worked with thousands of practices across New South Wales for AgPal in that time and supported them through their accreditations. And then I transferred to manage the QIP consulting, so the consulting arm of AgPal, way back in 2018. And in that role, I actually get to get my hands dirty, dig in, immerse myself in the general practices that I'm supporting and actually get to support them through their accreditations and clean up things at the other end if there's anything left to clean up. So These are a mix of the data that comes directly out of your PHN, but also out of the the Australian Commission for Safety and Quality in Healthcare. But it's also a lot of my own lived experience that I've dealt with one-on-one with these practices. So this is the assessment outcomes data. This is readily available on their website at any time, and this is the Australia-wide data of the top non-compliances. I want you to take a quick look at these. A lot of them are going to come up in our slides in the next top 11. However, I do just want you to note that a few of them, see QI12B and QI12C, about halfway down there, a lot of them are actually in the same criteria and are really, really closely linked. So I've chosen to actually roll those in together because they really can't be separated out in the ways that you do respond to them. So a few times throughout my next slides, I am going to be using the words moving parts. And I really, really want to just hone in on what I mean when I say moving parts indicators. These are my pain in the bum indicators because the reason that these indicators are often not met is not because of a lack of understanding from the practice. It's because of lack of preparation and oftentimes not on the practice manager's part. So if there's lots and lots and lots of pieces of evidence that has to go into one single indicator to meet it, and you are missing one tiny, tiny element, the entire indicator is not met. So when I call out the moving parts indicators, I want you to take note of that. And I'm not going to spend a whole lot of time around the understanding because I am going to assume that the majority of you understand it. It's just going to be a part of getting all your team on board is the reason that these are often not met. So let's start off with number one, which is the biggest one and the biggest non-compliance across the board, nationally and also in your PHN at the moment. It's GP 31A and 31C. So this is clinician qualifications. So again, perfect example of a moving parts indicator because to meet GP 31A, you need every single one of your practitioners to have registration, certification in their professional association, and evidence of CPD and evidence of CPR. Similarly, with GP31C, every single one of those clinicians needs to have evidence that they were trained in the equipment when they started. So the reason that this is a common non-compliance is, like I said, moving parts. You might have 9 out of 10 of your practitioners have everything and one of them has an expired CPR and just didn't have time to get it booked in. So that is not an understanding issue, that is the moving parts issue. So self-led CPD activities is another issue. If you've got allied health in your team and they are doing self-led CPD, sometimes they are not recording that as well as could be hoped, and they've got to quickly cycle back and write down everything that they needed to do for you. That can sometimes take time and therefore sometimes causes a delay on our end. External bookings for CPR and prioritization of this qualification. A lot of GPs, given the work that they do, don't always necessarily prioritize CPR. And that's neither here nor there. It's also because they only have to do it once per triennium. Sometimes they leave it right to the end of their triennium, which can sometimes fall out of the calendar years that we need as well. The big one for GP31C is the assumption of equipment competency. When you get a GP start in your practice, it seems really against the grain to ask them something like, do you know how to use an ECG? Are you confident in using that? Are you confident in how to work a height adjustable bed? Because the assumption is that, of course, they will have done this in the past. Of course, they will have had this experience, and it could even come off as offensive if you're asking them for this. That being said, do they know how to use your ECG? And do they know how to use your height adjustable bed? And this is sort of, therein lies the rub. And of course, most GPs will have the wherewithal to go and ask your nurse or ask another of the GPs once they've started to say, hey, can you give me a quick show of this equipment? But we have no documentation of that. And lastly, the other issue with GP31C is the insufficient in-house expertise to provide the equipment training. If you have a nurse that leaves and she has not written down anything around the sterilizer, or she got trained on the sterilizer by the manufacturer when they came in, and she leaves and there's a gap between the new nurse starting, you've got no one in that practice to be able to train that nurse, and you have to get that manufacturer or their online modules or something like that out for that nurse to be able to upskill in that particular equipment, which can cause a delay and sometimes is overlooked because there's a lot of other more important things going on when a new nurse starts. So, a few ways to address this one to keep it off your list. Have a check if you're doing hard copy HR records, like in manila folders, great, that's not an issue. Just keep a hard copy checklist in the front of it so that you can do a quick check of the records whenever you're in there and updating things. One HR record per year is super handy, but if you don't have the time for that, one HR record audit 2 months before your on-site assessment is going to serve absolute wonders. I have an HR record template that I believe is included in the supporting documents for this webinar. Just ticking through that and checking all of those bold ones and making sure that you've got every single thing for every single person is absolutely going to save you time in a whole host of the top 10 non-compliant indicators. Electronic registers are great for tracking expiry dates on things like CPD, CPR, and registration. Highly recommend that you use that if you've got a slightly bigger team. It will save you time over the long run. Equipment training, just include it on your induction checklists, and that's enough evidence, written evidence, to show that people were trained. And if you ever have any new equipment come in, make sure either the manufacturer trains at least one team member who can train the other team members, or trains the entire team together, or provides an online module that the team can complete, and then just record just that individual training when it occurs. There are other ways to do that. If the inductions obviously have passed, there are little checklists that we can do that are just a quick competency check that you can go around and do right before assessment, and that can be really helpful as well. Try to have some evidence of induction for GPs that includes some really key points. It does not have to be as excessive as that for your staff. Obviously, they are contractors, but contractors do still need to uphold a series of things that are important to your practice, like evacuation and emergency, and know how to report an incident. And they also need to know how to use the equipment that they're using and get their logins and things like that. So honestly, this can be 2/3 of a page, and it's really, really operational. Whenever you do refresher training, just use an itemized list of the equipment so you can tick that off, and that can be done in a clinical meeting. So, number 2. Again, this is a moving parts indicator, because in order to meet this indicator, every single one of your GPs needs to be doing every single one of those dot points. And oftentimes it'll be 1 or 2 GPs that are missing 1 or 2 of these things. Family history and social history are the 2 main offenders that are being missed, and it will make the entire indicator not met. So, registration forms not capturing these areas is a big part of why it's not met. I really, really respect trying to get registration forms onto a single page, even as a consumer myself, seeing 3 or 4 pages and you look at it and you're just like, I'm not filling that out. I do have a 1-page registration form template. If you'd like it, please reach out to me and I'll be happy to share it with you. And it does capture all of the items. So try really hard not to skip important bits and pieces, because then you have to rely on your clinical team to check it, and they've got other things on their plate. Fragmented intake processes can also be an issue. So it goes through reception, then through the nurse, then through the GP. This can be really, really beneficial in terms of collaborative care, but it can also open the door to clinicians assuming that someone else has done what is their responsibility. So if you're going to do that kind of approach, you need to be very, very clear on who's responsible for what. And obviously GP capacity and nurse capacity. If you've got 6-minute consults and you're there trying to figure out one simple thing that the patient has come in for, there's no way that you've got time to check family and social history in that consult. So, ways to address it. I have a health record audit tool that I will be sharing after this. This is a super easy way to double check things that areas where a GP might be slowing down on. I think my record audit tool has a recommendation of 10 health summaries to be checked. I don't even care if the GP does 3. It's more about reading the column of what is being assessed against and understanding what's important to include in a health summary than it necessarily is going through the entire audit themselves. 3, 5, wonderful. 10, amazing. So pulling using your PDSA cycles to pull reports from missing items in the system, it kills two birds with one stone. Not only are you cleaning up your data and making sure that you're meeting QA 21A, it's also going to meet QA 32A, which is, sorry, 32B, which is your PDSA activity. Make sure your registration form captures everything. See where your nurses and GPs can say, sorry, your nurses and reception can save your GP some time. And make sure to use those drop-down lists instead of free text. It's just going to make everything so much easier on the other side when you're trying to use coding for preventative care. Workplace immunizations, again, a moving parts indicator. It's usually that one or two people are missing their refusal or consent or missing one particular vaccine, and the entire indicator becomes not met. So a big one that's not understood about this is that serology is amazing, but it is totally optional. You don't have to have serology for every single staff member. However, if you do have their serology, it is really, really good because it means that their refusal can be cross-checked against their serology and their immunity. So there's a whole host of reasons people can refuse immunizations. One, it could be that they've got serology that shows that they are already immune and they no longer need any further vaccinations in that space. Two, it could be that they're just pretty damn sure they got that in high school or they got it at their last job, don't have any evidence of it, but they're pretty sure they're okay, so they're going to refuse this time. Fine. Three, conscientious objector, just doesn't want it for their own health or personal reasons. Fine. Those last two, if you're refusing, you do still need to fill out a refusal form. We still need to have your refusal on record. It doesn't matter. It just means that it might, especially if you are a nurse, it might impact the type of work you can do. For instance, if somebody's not immune to hepatitis B, I wouldn't recommend them having cleaning up blood and body fluid spills. If somebody hasn't got the whooping cough vaccine, I wouldn't recommend that they're handling infants. So using the immunization history download that's available through MyGov was one of the best things to come out of COVID. And I say this as a Queenslander speaking to Melbourneites, so I do apologize. My heart goes out to you. I do appreciate that you had a much harder time during COVID than we did. But the immunization history download was really, really handy. And you can direct your staff if they want to refuse because they're just not sure if they've had it or not. Feel free to direct them to give you your immunization history off there if they'd like. It's a really easy way to get around it. New staff members also really throw this indicator off. They might have started 2 weeks ago and you just haven't got around to getting their immunizations yet. And the other big one is that ongoing boosters aren't monitored. So you might have done everything right when everyone started, but you haven't been checking that flu vax every single year. And that might be what throws you off. So CPR for non-clinical staff, another moving parts indicator. New staff are almost always the reason for this being not met. Someone started 1, 2, 3 months ago, they haven't passed probation yet. You don't want to pay for their CPR because they haven't passed probation and you're not sure they're going to stay, but you've got accreditation in that time. So you've got to make a decision whether to pay for their CPR and get them through or whether to wait, etc. Some people just choose to get their CPR before they start, but then that will limit your pool of employable people as well. So another big one is a lack of understanding of who requires CPR, and this comes down to allied health, whether allied health are actively contributing to your health records, whether they are attending your clinical meetings, whether they're listed on your website and therefore very clearly part of your team, then they're going to need CPR. And a lot of arguments personally may ensue when that comes up because a lot of them don't expect it, and that takes some time to resolve. So that's something that needs to be gotten onto really, really early. And misunderstanding around the 1-year expiry and the 3-year requirement is something that we used to get all the time questioned about as client liaisons. While CPR certificates expire annually, for accreditation purposes, you only need to have undertaken CPR within the last 3 calendar years for non-clinical staff. Once per triennium for GPs, for nurses and non-clinical staff, once every 3 calendar years. So you might still have an expired CPR certificate, but it might still be valid for accreditation. And because a lot of staff don't fully understand this, they'll go, "No, mine expired." They don't give you one that they've had from their old employer that's actually still within the window. So really, really important to understand that difference and to ask anyway. And just say, "Give me the most recent one you've got and let me just look at it." So because chances are they might actually have one that will still meet that need. A couple of ways to meet this is getting all stuff done at once is really, really handy because then you only have to think about it once a year. But it obviously can be costly and you've got staff changes and there's a whole host of things to think about there as well. So it is something to sort of weigh up. All right, patient feedback. Now, all three of these fall into the top 10 non-compliances Australia-wide, all very close together. The first one is related. Ooh, my Siri just decided to try and help me. Apologize for that, guys. The first one relates to your CFEP in-sync type of surveys, those big surveys that you do proactively every 3 years. Second one's about responding to that feedback, and the third one is about closing that 360-degree loop with the people who give you feedback. So main reasons this is not met is that people just do not understand how little patients want to do these surveys. So people do struggle to realize just how long it takes to get the amount of surveys that they require. So you've got to start early. Misunderstanding that both B and C, I'll just quickly jump back to them for a second. So B is analyzing, considering, and responding to feedback. And C is informing patients and relevant parties about how that feedback has been used to improve quality. People sometimes misunderstand that B and C cannot be met unless you've done A, and so they don't try to put forward any evidence about it. B and C can absolutely be met with other feedback that has come in ad hoc over the last 3 years. So if you've got a really great example of where you've collected feedback from a staff member and you've closed that loop and given them information back, that will still meet those indicators without you having to have done the CFEP survey and then hung it up in the reception area. That's certainly the easiest way, but it's not the only way. People will sometimes not log general feedback because it's not seen as important as complaints. If you've got 7 patients in a row that say, "The waiting room's really, really cold," it's like, sure, you might log that once and there's no immediate improvement that has to come out of that. You don't have to have an improvement activity come out of every single piece of feedback. But if 7 people over 2 weeks tell you the waiting room's too goddamn cold, you can see that there's a trend that's starting to appear and you can go, "You know what? We've actually had 7 people in 2 weeks tell us this, or we've had 10 patients over the last 3 months request that we start doing flu clinics or Aboriginal health assessments or something like that, or wish that they would have more information on preventative care." Now that we've gotten a sufficient amount of that same feedback in that same vein, it is worth doing something about it. So logging general feedback, regardless of whether you have an outcome or not for it at that moment, is still really important to acknowledge trends. Taking and retaining meeting minutes. So often practice are absolutely considering feedback and then doing something about it and not writing it down. And I don't care if it's meeting minutes or if it's an email summary after that meeting to the team that says, "Hey team, as discussed today, such and such brought to our attention that there's no baby change table in the toilets, and they've gotten 7 pieces of anecdotal evidence over the last few weeks about this. Such and such has decided that we're going to put a baby change table in there for the benefit of our patients, and we have told such and such to order that baby change table, and it should be here by the end of this month. Cheers, practice manager." Fine. That is a documented piece of information that I can look at and I can say, yes, you absolutely discussed some feedback and absolutely had an outcome. QA 1-2B met. Getting too good of a result on the survey and being stumped on how to improve. I see this so often that 95% of everything is just met. And so everyone's like, well, this is great. Like, now what? How do we fix it? How do we do anything? Because we're perfect. Look at your free text feedback. So often there will be a little tiny nugget in that free text feedback that says something about, "I just wish that you guys had lollipops for kids when they got vaccinations," or "I just wish that you had," there can be some really, really tiny things. "I wish I had better access to the female GP," something like that that you can build on. And there's always ways to proactively say, hey, look, thank you so much for your amazing feedback. We respect that our timeliness is really valuable to you because you scored that so highly. In order to keep that going, we are going to implement X, Y, and Z in order to continue to meet demand. So there's always ways to find improvements there. All right, number 6, risk management. This is probably the first one that we're going to get to that really truly does come out of an understanding differential rather than a moving parts. It's a pain because most practices are incredibly good at clinical risk and individual risk, managing risks directly for patients, but don't think too much about operational risk in a documented sense. You're all doing it constantly, otherwise the doors wouldn't still be open. You just haven't thought about writing it down or thinking about it proactively. Oftentimes it's done reactively because all the way through the 4th edition, first through 4th, we were expected to do it reactively. So oftentimes some practices will fail to see the value of risk and see it as another bureaucratic approach and another document that they have to fill out. And they've got a lot of other things going on. And oftentimes I do see really overly complicated risk registers that are just so much more than any practice needs. So it's a matter of really bringing that level of complication down and going higher and higher and higher in your levels. Instead of being really specific about what kind of patient incident you might have, the risk that you should be managing is just incident in clinical care, not patient misidentification, not expired medication administered, not, these really specific things. It's incident in clinical care. Manage that risk. And the other thing is that people will do these wonderful, beautiful risk registers, but they're not maintaining them. And so they're not actually using them and putting it into place. And we can see that when we come in and we have a look. So those are the big issues. And I think the best ways to tackle this are, 1, a very simple risk register, which I think I'm providing as a template. If I'm not, feel free to email me and I will give you one. They aren't the only way. If you minute your meetings really well, and I can see that you are discussing risks often and considering them often, you will still be able to meet this. There is nothing in the indicator that says you must have a risk register. It's that we can see that you're documenting and considering your risks. So they are the best way, but they're not the only way. Think of all kinds of risks, not just the clinical risks. So HR, location, privacy, physical risks, reputational risks are huge. And they're all really valid. And sometimes they're the actual ones that pose the biggest risk. A lot of the time your clinical stuff's going great, but it's that your operational or HR or finance stuff isn't in line. And don't overburden the register. Set realistic timelines to look at it. You don't have to look at something that's not going to change every 6 months. Like if it's a really, you might have a building that's in a flood zone. If you haven't moved from that building, the risk is going to be the same unless they have diverted, built a dam down the road from you in a year's time. So it might be a high risk, but it's not going to change. That risk is not going to change. There's nothing you can do about it. So you would set that annually. You wouldn't set that monthly, even if it is quite a high risk to you. So think about the most realistic ways that you can adapt those timelines. And if you resolve a risk to the point that it's no longer a risk, get rid of it. Take it off your risk register. Don't burden yourself checking something all of the time that you have managed to the point that it's no longer a risk. All right, vaccine management. So this one, obviously, I've selected GP1C, though GP1A, B, and D do sort of tend to come up. They're all covering pretty similar stuff. So the reasons that GP1C, 61C is often not met. Annual audit. People either forget to do it or they forget to keep the evidence that they did it 6 months ago. You're like, yeah, no, I did that. I finished the audit and then I just threw it out because it's finished. And I agree, but keep that piece of paper for accreditation so that we can see that you've done it. Oftentimes this will happen when a nurse changes over. Like one nurse will have printed it out, done it by hand, and then just tucked it somewhere in hard copy, and the new nurse doesn't find it. So make sure you do the annual audit. Not requiring the responsibility in the position description. I see this one come up a bit. It's a little bit nitpicky when the surveyors do call this out because a lot of the times it is recorded in the cold chain manual, but just make sure that it is called out in the position description as well, just to be sure. Late refrigerator maintenance, as in you've booked someone in and they just don't have an availability to come out before your assessment. I've seen that a few times. Forgetting to reset the thermometer is a big one. So people are doing the morning and afternoon every single day, but they're not pressing reset. And so you're actually not getting the temperatures from the last 24 hours or the last 12 hours or however long it's been. So that has sometimes shown that someone has an out of range temperature, but they haven't when you check the data logger. Incorrect storage layouts, so having vaccines that are pressed against the side walls, having same name vaccines on the same shelf, not using those open weave baskets, and having one or two expired vaccines tucked in the back of the fridge, awaiting public health or anything like that. All of those are oftentimes the issue. Almost never is it actually the issue with temperature recording. Most people are doing that pretty well, surprisingly. Like, because I always thought that that would have been the one thing that people would get caught out on because it requires, such focus, but no, oftentimes that one's actually been done quite well. So make sure you do the audit. The stock rotation protocols that you have for your medications management, make sure they extend to your vaccine fridge. I know you've got to try and keep that fridge closed as often as possible, but get in there and make sure that that stock rotation is happening as quick as you can. Check your position descriptions and support the cold chain coordinator to be the champion of cold chain. That document is their document and they are responsible for maintaining that, and they are responsible for training or ensuring that the online module training is provided to the other staff. Let them take ownership of that. Not only does it take something off your plate as a practice manager or as a owner, but it empowers your staff member to take responsibility for an area that they are the expert in. So that's my biggest takeaway for this particular indicator. Incidents and near misses. So these two are so interlinked that you can separate them. They both do often come up in the top 10 nationally and in this PHN. The biggest issue with incidents is that practices don't want to admit that one happened. And that is so detrimental because it means that the no blame philosophy isn't being upheld culturally in their workplace, but it also means that you're not learning from them. So this is something that really needs to get tackled head on. Incidents and near misses are inevitable. Unfortunately, you will have one in your work time eventually, but they are also a really, really, really great learning opportunity. Often teams will misunderstand what an incident or a near miss is, and so therefore won't record it or report it because oh no, that was just a mistake, not an incident, not a near miss. So making sure that they're really, really clear on what incidents and near misses that are reportable are so that you can learn from them. Another big one is no obvious improvement opportunities that have resulted. So people just don't think to record it if there's not an immediate improvement that might come out of it. And that one is a concern to me because so let's say patient was misidentified and notes went into the wrong best practice file. It was immediately rectified. It was seen. It was fixed at the spot. Everyone was fine. That near miss, in essence, in and of itself, may not require an immediate improvement opportunity because the time that it might take to implement that improvement opportunity might not directly correlate with the level of risk that is and how often it happens. But if it happens 4 more times in the next 3 months, it's time to go, all right, this is actually an issue with this particular area, and we need to implement a policy or procedure that says only one best practice file open at any time. Or for this particular GP that it keeps happening with, this GP needs to do a double check and we're going to stick a sticker on his computer or something like that that reminds him to do it. So incidents and near misses, if the improvement opportunity, if there is an improvement opportunity that's obvious, but it doesn't, the effort that it takes or the financial investment that it takes to try and implement that opportunity doesn't currently weigh up against the risk, you might not implement it on the first instance. But if there are 2 or 3 other instances, that's when it might be like, oh, okay, you know what? Actually, we do have to instate something. So that's why it's important to log the incident or near miss regardless of whether there is an improvement opportunity or not, because you start to see those trends. So Obviously, how to address it, incident register. That's, I just like, I know that maybe it doesn't state that explicitly, but I honestly, it's one of those ones that I just have an incident register. You're absolutely better off having one. Um, discuss the incidents. Again, I don't mind if this is a minuted meeting, a formal minuted meeting, or if this is hallway chat, staff room chat, water cooler chat, whatever it is. Send that email I was talking about after and say, hey, as discussed, here's the incident that occurred. Here's the outcomes. Here's the responsible person who's going to be undertaking those outcomes. By the way, I've popped it in the incident register. And there is my documentation. And yeah. So number 9, doctor's bag. I am very aware of time. Thank you, Nat. Sorry. Doctor's bag, it's another moving parts one. There's almost always one little tiny thing missing. And oftentimes it doesn't get caught out because the GPs aren't often doing the home visits and therefore not often using the doctor's bag. So they don't notice that it's missing. Or they're using it often and they haven't told the nurse to restock it. That's another big one. Expired medications, again, if they're not using it often, they might miss expired medications. They might have one tiny little nasty morphine in there and no Schedule 8 book in the doctor's bag. They might, this is my biggest bugbear in the entire world at the moment. They might buy an off-the-shelf doctor's bag that sells itself as a fully fledged doctor's bag that has never once been cross-checked against the RACGP standards and is therefore missing a ton of stuff that you actually need, but you've paid top dollar for the experience. Check any off-the-shelf bag that you purchase, please. An unreasonable list of please add to bag items. I've seen some that are effectively an assemble your own doctor's bag with 7 or 8 items. Really, that add to bag list is reserved for expensive stuff like the ophthalmoscope, the oroscope, or the stethoscope because people don't like sharing them. Sometimes people will have an absolutely perfect doctor's bag, but during the doctor's interview, the GP will not know that it exists. So make sure your GP knows where it is. And child-size Goodelles. Oftentimes people have the adult ones, but won't have the kids ones in the bag. Get a doctor's bag checklist. Check it 3 monthly if you're not using it often. Check it monthly if you are using it often, but you should be fine. Do it at the same time you do your emergency trolley. If you can, take the S8 drugs out of the bag if you really don't need them in there. It just complicates things. Involve the GPs in selecting the contents of the bag. In addition to what is required for the RACGP standards, they're going to know what they want to use. Number 10, business continuity and information recovery plan. The biggest issue with this one, people are still using the SIS manual, the one with the big hand. That was superseded like 4 years ago now. So get rid of it, start again. I believe if I haven't provided you with a template in the external resources, email me and I'll give you one. Privacy policy needs to be updated annually. Make sure that you check it annually. That is the one policy out of all the policies that I insist you check annually. There are others that you can push out to 2 or 3 years depending on risk level and changes, but annually for the privacy policy, please. Use the RACGP one. They update it regularly and it covers everything that you need and you are covered if you are using their one. Don't confuse the IT, so business continuity and information security plan. It's not the same as the emergency response and recovery plan. So those 2 things are totally separate. The names are really confusing. Make sure you've got both. And don't put too much trust in your IT provider to do the right thing without your oversight because, and I'm one of them, IT is an incredibly alien topic to a lot of us. We just trust that the people that do the IT know what they're doing. If we're not looking over their shoulder on those few really key things, they may be taking us for a ride. And I've seen it and it's horrible when it happens. So make sure that you know how often you have the restoration tests. Make sure you get evidence of a test restoration before your survey because they can really drag their feet. All right, last one, bonus one, because I can't count, medicines management. The biggest issue with this one is 1 or 2 expired medications, especially patients' own medications that are stored at the practice that are expired that haven't been thrown out because you don't have patient permission. That sometimes really sets people off. Making sure that your consumable expiry rotations are in place. They don't need to be formal. You don't need to keep documentation, but you do need to make sure they're happening maybe the first of every month or whatever particular date that you choose. Sample medication label templates. A lot of surveyors will actually like to have these on hand, or at least available to be printed out quite quick. The big one that I see here, which is such a tiny thing, but so easy to avoid, is that people will print them in black and white, so the keep out of reach of children is not in red. So make sure to print those in color. S8s are the biggest offender of this indicator not being met. If at all possible, if you are near a pharmacy and don't often utilize morphine, please just don't store S8s on site. They just require so much additional work and they have so much additional risk. If they're not relevant to your patient population and the work that you are doing, try your hardest to have them stored at the pharmacy. If they are relevant, make sure that you have every single little duck in a row that you can. And remember that every single state is different and there are different levels of risk appetite around S8s. If you are if you are on the border, it's good to know about both sets of legislation just so that you're aware. Obviously, you'll be sticking with whichever legislation that you are in the state of. But we have had, and I'm from Queensland, we've had a couple of instances in the past where a Tweeds Head sort of border has been misunderstood as assessed under Queensland standards versus New South Wales, etc. So just being aware of what the differences are so that you can be aware of those. And audit your S8 book. A lot of people will keep the book beautifully and immaculately, but they're not auditing it against what they have on hand. So 6 monthly is good. March and September is an easy way to remember it. 3 of the state legislations actually do say March and September is mandatory. Okay, very, very quickly, I do want time for questions, so I'm just going to run by this in 5 minutes, 2 minutes. The biggest, highest risk indicators that will result in a resurvey if something is really, really, really wrong is sterilisation in GP41, maintaining vaccine potency in GP61, follow-up system, so really, really old recalls and reminders that haven't been actioned, and Schedule 8 medications in QI22. So those are the 4 that you need to be super duper aware of, because if they are wrong, they could result in a mandatory report to the Commission. Very, very quickly, easily avoidable mistakes. Prep your team on interviews. Use the AgPal. I think QPA even does have a resource for this too now. Use the template for interview questions if you can. If you need that template and you're not with AgPal, you're with QPA, reach out to me. I'm more than happy to provide you with the particular indicators that are often assessed. QPA and AgPal and all of them will have slightly different ways they approach their interviews, but I can give you a bit of basics. Have 2 people in the room if you need to. That's totally fine often. Do the consumable stock check, do the HR record audit a week prior. That's always a big, huge thing. And minute at least 1 team meeting right prior to it, because it can tick off a hell of a lot of indicators for you. All right. Sorry, I sped run the end of that, but Nat, I'll hand it back over to you for the last couple of minutes.
No worries. Thank you so much. So while we give time, if you'd like to have some question, if you've got a question that you'd like to ask or some knowledge that you wanted, if you want to pop it in the Q&A box now. I will just cover, we do have an accreditation page on our website that has links to all sorts of useful things in terms of the actual standards and CPR providers and options for a risk management tool that you can use in your practice. So I always recommend jump on there and have a little look. Obviously, your relationship manager at the PHN is always there, so you can contact us through primary care at nwmphn.org.au or giving us a call, and we'll be happy to answer your questions for you. Next slide. Thanks, Riley.
That's me. I forgot I was helping.
Okay. You are helping. The other thing too, I think one of the big tools that we do have at the PHN is health pathways, and I think a lot of people think of them as clinical tools for GPs and nurses, but there is actually a bunch of administrative support pathways on there as well. So next slide. All sorts of things that can assist you in your accreditation journey. and sort of answering those questions, directing you in the where to find the right information so that you do have everything you need ready for your policy and procedure manual, your self-assessment, and your on-site visit. So in terms of accessing health pathways, we have now moved to a single access log-on method. So you will need to create your own profile. So there's a lovely QR code there if you want to register, or you can visit melbourne.communitypathways.org.au and that will direct you to create your own login. All right, let me have a look. We might have some questions here. All right, so a question, do we need to keep a Schedule 4 book or just document in the patient file what has been administered?
So in the patient file, what's been administered is really good. Some some practices absolutely do choose to maintain a Schedule 4 like impressed stock register, which is absolutely fine. That's just for stock and expiries. It's not required in most, if not all states by legislation. Don't quote me on that, but in the states that I'm most familiar with, not positive about Tassie or Northern Territory, but in Melbourne, which is
Schedule
where
8 only.
Schedule, it's not required for legislation that you have a Schedule 4 register whatsoever. It's just that you need to be recording that in the health record notes.
Wonderful. Another question around GPs not documenting consent for nurses to administer vaccines and medication. And guessing this is probably for non-nurse immuniser. Yeah.
So this one actually has come up a couple of times. As a general rule, they need to be putting that in the health records themselves as soon as they are able. So if they have remote access to the health records, they should be being able to do it by remote, saying that they've given that advice. If not, they need to do it as soon as they're back in the practice. So the nurse needs to be addressing that if they've got that via verbal from doctor, administered as per X, Y, and Z, and putting those notes in themselves. And then hopefully in the next day or two, there'll be a GP consult note that's going to match up exactly with that when they've gotten back to their practice.
And this would be a really good thing to put in your incident register or your near misses or your risk register, because it is something, if it's happening consistently, and then taking it to a meeting, taking it to your practice manager. So, and then there is another question here. Can RNs administer vaccines without a check? I was going to say, I'm happy to answer that one. You must be a nurse, given the Victorian context, only if you are a nurse immuniser, and there needs to be a clinician available access to you for advice. So if you are not a nurse immuniser, you require a order every time. All right, wonderful. So I think that's it for questions. I was going to say last chance, so please jump in and pop your questions in. Otherwise, thank you very much, Riley. I was going to say I've been to this twice now and I've got something different out of it each time. So hoping my own accreditation will be really good next time, which will be great. Thank you everyone for attending. We would love some feedback. So there is a QR code there if you can scan that and answer the questions. Particularly really interested to hear if there are sessions or resources that you are missing or you really feel you would like. We'd really love to hear about them. So I was going to say, this is our feedback register before you go and create yours. But otherwise, thank you very much for attending this evening. I hope you've all learnt a few things and you're all going to do wonderfully on your accreditations. Have a good evening.
Bye, everyone. Thank you so much.